Hearing for the Subcommittee on Health will now come to order. Today we will be discussing the VA's amputation system of care and the services provided to veteran amputees. At VA, prosthetics include a wide range of devices from eyeglasses to hearing aids to prosthetic limbs. If I could manage to turn the page. Although our main focus today will be on amputee prosthetics, I want to highlight the VA's recent failures related to purchasing and budgeting for prosthetics. In July, committee staff visited the Rocky Mountain VA Medical Center in Colorado and discovered that thousands of prosthetic orders had been improperly canceled. As a clinician, I was appalled that this could happen, and it is clearly unacceptable. Earlier this month, I was informed that the VA's claimed budget shortfall for healthcare, which they argued was related to the cost of prosthetics, was a huge exaggeration. If the VA can't even budget correctly for prosthetics and routinely cancels orders, how can veterans, especially those living with the visible wounds of war, trust that they will receive the prosthetics they need? We cannot and should not accept this as status quo. Prosthetic care is essential to the bedrock of VA's mission. This means assisting veterans with regaining functionality and working to improve their quality of life after limb loss as a result of their service in uniform. Each year, VA sees approximately 95,000 new amputations, primarily due to vascular disease or diabetes. However, VA also treats a significant number of post-9/11 veterans with combat-related amputations. As veterans' needs evolve, it is the VA's responsibility to provide the highest quality of care and advances in research to meet those needs. VA services vary across its facilities, but its 7 fully equipped regional amputation centers can offer comprehensive care, from prosthetic fabrication to full inpatient rehabilitation. These centers should set the standard for world-class care for prosthetics, and in many cases, they do. VA's amputee care serves nearly 100,000 veterans annually, with many receiving exceptional care. However, the committee has heard of significant delays in veterans receiving their prosthetics. For one example, one veteran recently told my team that he has spent over a year waiting for a functional prosthetic leg. For 10 of those months, as you can see here, he had to rely on duct tape to hold his prosthetic together. Since March of 2023, he has been forced to travel out of state every 3 months for appointments. Despite these repeated trips, there is still no timeline for when he will receive his new prosthetic limb. Now, it shouldn't take a congressional hearing for him to hear back from the VA or for the VA to respond to this veteran. And he should receive the latest state-of-the-art updated prosthetic limb now, ASAP. Veterans depend on these devices for their daily lives, and waiting for years for a prosthetic limb, socket, or terminal device is unacceptable. I expect we're going to hear similar stories today. Like other VA offices, VA's amputation centers face understaffing and are often riddled with bureaucratic inefficiencies. These challenges, exacerbated by the Biden-Harris administration's poor leadership and staffing decisions, are uniquely devastating to veteran amputees. These bureaucratic delays not only impact veterans' physical health, but they also take a toll on their mental well-being, resulting in more time in healthcare facilities and less time spent with their families, enjoying life, or advancing their careers. As a veteran and a physician, I know we can do better. In addition to these issues, veterans face barriers in accessing adaptive prosthetic limbs and terminal devices for sports and recreational activities, devices that can be life-changing. The committee has heard numerous stories of veterans being denied these adaptive prosthetics. That's why I recently introduced H.R. 9478, the Veterans Supporting Prosthetics Opportunities and Recreational Therapy Act, or the Veterans Sport Act. This bill would ensure these adaptive prostheses and terminal devices are defined as clinically necessary for veterans living with limb loss. I am committed to working with the VA to ensure we provide our veterans with timely, high-quality prosthetic care that they deserve so that they have access to what they need to live the most fulfilling life possible and the most fulfilling work. During today's hearing, we'll delve deeper into these issues, hear from witnesses, and work towards common sense solutions. Thank you all for being here, and I look forward to a productive discussion on this critical topic. Before I introduce the witnesses on our first panel, I ask unanimous consent that our colleague, Representative David Rouser, be waived on for this hearing. Hearing no objection, we will move forward. I now will yield to Ranking Member Brownlee for any opening remarks she may have.
Thank you, Chairwoman Miller-Meeks, and thank you to our witnesses for being here today. Veterans living with amputations deserve access to the most comprehensive pre- and post-amputation care that VA can provide. I'm looking forward to hearing from our VA witnesses on panel 1 about how they currently provide this care and areas of improvement and advancements that they are seeking. I'm also looking forward to hearing from our panel 2 witnesses about their own experiences and experiences of those they represent with VA care. Veterans with amputations from any cause must receive well-coordinated and comprehensive care from providers including their physicians, physical and occupational therapists, prosthetic providers, and mental health providers. It is crucial that we support the provisions of all these types of care to ensure that every veteran receives the unique combination of these services needed to meet their medical and personal goals. While I understand that not every VA facility has the capacity to manufacture prosthetics, I look forward to hearing more about how VA is working to build in-house capacity while continuing to work with contracting and vendor partners, improve communication with providers in the community, and ensure it is providing wraparound services for veterans in its care. I'm especially glad to hear of the work VA is doing to both prevent disease progression, to avoid amputation, as well as to the advances in technology and treatment options available for those who do receive amputation. This includes VA programs like the Preventive and Amputation in Veterans Everywhere, or PAVE, a program that has been established at every VA medical facility, and research through the VA Center for Limb Loss and Mobility. As we continue to advance our medical understanding of these diseases, they can lead to the need for amputations, that would lead to the need for more amputations. We must continue to improve the care we are providing our veterans. It's also clear we're living in a time of exciting advancements for prosthetic options. With the use of telehealth technology, VA providers can be more connected than ever to ensure veterans and other providers are communicating about veterans' prosthetic needs. Additionally, with advances like 3D printing, we have more control than ever over how and where VA can manufacture prosthetics and ensure a proper and effective fit. I look forward to hearing more about how VA is already using this technology and how it can be expanded upon. This will be especially important for women veterans who make up a small but growing number of the total patients with amputations that receive care at VA. As GAO notes in its statement for the record for this hearing, women veterans have reported facing difficulty in finding properly fitting prosthetics as they are generally sized for men. However, the ability to 3D print prosthetics that are designed to fit their bodies and accommodate their clothing and shoe options will be revolutionary for women veterans. I'm also grateful to Mr. Ramos and Mr. Brown for being here and willing to share their experiences and expertise, as well as Mr. Restivo, who has submitted a statement for the record. I find this committee's work is most impactful when we can hear a variety of veterans' experiences with the care VA provides and identify common ground where those services and care can be improved. I look forward to continuing that today. Finally, I welcome hearing from our witnesses at the Amputee Coalition about its work to support VA's amputation care. Having the support of a community of individuals who understand the challenges of living with any physical change is crucial including for veterans living with amputations. I'm glad the coalition can provide that through its peer visitor program and national support group network, and I'm looking forward to hearing more about the types of support that we can expand upon. Thank you again to our witnesses and for being here, and I yield back.
Thank you, Ranking Member Brownlee. I'd now like to introduce the Panel 1 witnesses. Testifying before us today, we have Dr. Christopher Saslow, Assistant Undersecretary for Health, Patient Care Services at the Department of Veterans Affairs. Accompanying Dr. Saslow, representing the Department of Veteran Affairs, are Dr. Joel Schulten, Executive Director, Physical Medicine and Rehabilitation, Dr. Ajit Pai, Executive Director, Office of Rehabilitation and Prosthetic Services, and Mr. Drew Craig, Design Chief, Enterprise Measurement and Design Director at Veterans Experience Offices. Dr. Saslow, you're now recognized for 5 minutes to deliver your opening statement.
Good afternoon, Chairwoman Miller-Meeks and Ranking Member Brownlee, and members of the subcommittee. I appreciate the opportunity to address the subcommittee today regarding VA's amputation system of care. Joining me today, as you heard, is our Executive Director for the Office of Rehab and Prosthetics, Dr. Ajit Pai. I'm also accompanied by the Executive Director of Physical Medicine and Rehab, Dr. Joel Schulten, and Mr. Drew Craig, who's our Design Chief for VA Enterprise Measurement and Design Directorate. My colleagues and I are pleased to share how VA cares for veterans with limb loss. Overarchingly, the department employs an interdisciplinary, team-based approach focused on maximizing each veteran's functional ability and independence. Each amputation procedure presents unique challenges which requires specialized follow-up care. VA is committed to building on our record of excellence when addressing amputation-related needs of our veterans. We provide lifelong specialty care benefits, which includes ensuring access to advanced prosthetics and instructor rehabilitative services. VA's amputation system of care connects the nation's heroes to the expert services as close to their home as possible. In fiscal year 24, the amputation system of care provided care to 18,387 veterans through 38,122 encounters that included 7,896 virtual visits. The roughly 18,000 veterans we cared for represents a significant 12.5% increase in our prosthetic health delivery over FY23. Further, new patients experience a low average wait time of 26.5 days. Patient satisfaction remains high in FY24, with a 95% of our veterans reporting feeling respected during clinic visits and 92.8% reporting satisfaction with their inclusion in care delivery. The amputation system of care model emphasizes lifelong care, which centers on the whole health of each veteran, including physical and mental well-being. Key pillars include preoperative education so that they know what to expect throughout their wellness journey. VA performs annual assessments thereafter as part of the whole health approach, which incorporates peer support and adaptive supports. We also offer comprehensive training for providers, specialists, patients, caregivers, and families. The Department of Defense and VA continue to collaborate to ensure seamless, high-quality care for service members and our veterans. VA and DoD utilize the Extremity Trauma and Amputation Center of Excellence to advance discovery and clinical practice. In service to veterans' whole health, the department creates new mutual educational programming and has created a network of amputation rehab coordinators. In conjunction with the DoD, VA's Office of Advanced Manufacturing allocates resources to develop and manufacture FDA-compliant advanced medical devices. In recent years, VA has made significant prosthetic advancements. We modernized our workflows through the implementation of 3D technology and through increased use of our telehealth visits. Other current innovations include a 3D printed foot system to enable veterans to wear shoes of any size, type, and heel height. VA is also testing a prosthetic system which allows users to feel touch through their prosthetics. The next-gen prosthetic devices utilize advanced algorithms to produce real-time measurements, which improves functionality. Surgical advancements include the Erdl technique, targeted muscle reinnervation, and FDA-approved osseointegration implantation. VA's groundbreaking research includes a multi-site study which tests an internally developed bone-anchored prosthetic docking system. At VA, we do much of our work to create positive veteran outcomes from within. However, we also rely on private sector partners to advance our mission of care. The network of veterans service organizations aid VA in caring for veterans experiencing delays or challenges with amputation-related care, and we continue to learn at every opportunity. Chairwoman Miller Meeks, Ranking Member Brownlee, thank you again for your opportunity to provide remarks on VA's holistic approach to amputee care, our commitment to ensuring that all veterans receive the solutions and respect they deserve remains steadfast. My colleagues and I are ready to address any questions you may have on how we can advance our mission.
Thank you very much, Dr. Saslow. As has been my protocol, I will defer my line of questioning to the end. I now recognize Ranking Member Brownlee for 5 minutes for any questions she may have.
Thank you, Madam Chair. Dr. Saslow, the GAO's statement for the record for this hearing identified that one of the issues facing VA researchers in this area, particularly for women veteran research, is recruitment, given the smaller population. Can you expand on how VA is addressing this challenge?
Yes, ma'am. I'll start off and then I'll turn it over to my colleagues. But we have a number of ways that we continue to advance the research of our female veterans. Of course, you mentioned the Recover Center, which we look at our 3D printed foot. But we also have done a number of research studies. Since 2017, we've actually completed 7 studies. We have 5 that are ongoing, and we have 1 that's a new study. We can actually offer that into submission for the record to actually go over all the different studies that we have been working through. But I'll turn it over to Dr. Pye and Dr. Skolton.
Okay, thank you, Dr. Saslow. I would also add that VA uses the electronic health record so we can identify and recruit subjects not only from the site where the research is being conducted, but we can actually recruit nationwide to improve the pool of applicants and increase the number of females in the study. The Office of Research and Development also includes funding support for travel in some of these studies where there is a harder time to recruit individuals, so they'll include the travel piece within the research budget. And finally, the Office of Research and Development also has developed the Women's Enhancement Recruitment Process, which is a toolkit that all researchers can use so we can increase the number of female participants in all of our research studies.
Can we have the new research that Dr. Saslow referenced written into the record? So I wanted to, in reading my staff report here, that 73% of veterans who need prosthetics is because of diabetes and not because of injury, which is just a shocking statistic to me. And I will just say that it seems as though the VA should be so razor focused on diabetes to prevent them ever having to come over to your department to get some form of prosthetic. So I think with women, I have to assume that I think the women population is about 20% in that area in terms of veterans who have received prosthetics. So I have to, my sense is that women are more likely to need a prosthetic because of injury and not diabetes, since they're younger. They're younger, and we didn't have women fighting in Vietnam, for example, and so forth. So, so if you agree with that assumption, then I'm very interested in this new study that you're talking about. But is there anything more that you can be doing for women to receive who need to receive a prosthetic because of an injury? Is there anything more? I know the 3D printing, I think, is a big one. I would be interested to know kind of what the women's satisfaction level is within the VA in terms of those who receive a prosthetic. If you could just talk a little bit more.
So I'll just comment on the fact that, as you heard me mention earlier, our satisfaction scores overall are very high. However, to your point, we continue to look at how we can focus our efforts on our growing population of female veterans, as you mentioned, and as they are a younger population and our fastest growing population. I'll turn it over to Dr. Skolton, who may be able to address a little bit further.
Yeah, unfortunately, I don't have the breakdown of VA trust scores, female versus male in the amputation clinic, but we do make every effort to outreach to female veterans with limb loss. We have, and we actually rely very heavily on our VSO partners to encourage female veterans to engage with VA and engage with the amputation.
So if you guys would just, I only have 17 seconds left, but if you could talk a little bit about what the VA is doing with regards to diabetes and addressing that so that we can reduce this percentage of veterans who need a prosthetic.
So we have a complete diabetes management team, and our PAC teams implement that with veterans. As you mentioned before, the PAVE score or the PAVE program helps with prevention of amputation. So there's a whole health approach essentially for the prevention, for the wellness and the diabetic management in order to prevent amputation care.
Thanks.
Thank you, Ranking Member Brownlee. The chair now recognizes Dr. Murphy for 5 minutes for any questions he may have.
Thank you, Madam Chair, and thank you all to the witnesses for coming today. I think your assumption that older veterans that are primarily female, I just think seeing a lot of older patients myself, generally diabetes is worse in older individuals, and as far as the amputation risk, it's much higher then. So, you know, guys, I serve on this committee because I'm not a veteran, but 1 out of 10 of my constituents are. And I am increasingly now just frustrated upon frustrated upon frustrated about delays, missed appointments, not being able to get referrals. I just want to pull my hair out. I had a long call with one of them yesterday who was at his wit's end and bounced around VAs, gets referred back and forth. You get sent to community care. The community care doctor can't send you to an appropriate referral. They have to bounce you back to your primary person who may or may not really get to that. And so the VA has lost yet another opportunity to provide excellent care to our veterans. And so, you know, when it goes on with prosthetics, this is a difficult time. I mean, I get it. It's not only a change in your ability to ambulate or to pick up something, it's also just a change in your entire mental calculus on how you view yourself. So delays, just in these type of instances where you have veterans delayed in wheelchairs for extended period of times, not ambulatory, not able to get things back. I'm reading about the difference between the philosophy of DOD versus veterans and how veterans actually prefer DOD because they want to get their life back and get back into action, if you will, is really something I think of particular note. So just if I can get a few questions, Dr. Saslow, can you tell me how the VA is ensuring that individuals with lower limb loss who are confined to wheelchairs due to malfunctioning prosthetics, legs, sockets, how do they receive timely repairs? How do they receive replacements that restore their mobility? And do you have any statistics that tell me about timeliness?
Well, I'll start off with the timeliness piece, sir, and that is that our access itself actually falls below the target of 28 days where our access metrics show an ability to get veterans into care within 26 days. And while that is not ideal,
Can you define into care?
getting into an appointment.
Okay.
So while that's not ideal, we certainly want to try to make sure that our veterans' mobility is addressed as quickly as possible. But I don't know if Dr. Skolton, you'd like to address it a little further.
Sure, and I'm not sure I can speak specifically to the sub-cohort of individuals you're referring to that have had a challenge with their prosthetic device or their wheelchair. We have done extensive work and we're launching a wheelchair repair contract, which will help improve access for veterans and the speed and efficiency to get wheelchair repairs made. We encourage for any veteran with limb loss that's engaged with their amputation team, they have the ability to communicate by phone, by secure message, and any way possible to try to connect with the team and allow for the appropriate appointment to occur in a timely manner.
Does the VA monitor anything of any complications that can occur from delays? You know, you delay a wound, You get cubitus ulcers, you get some other things for people sitting in wheelchairs, and et cetera, et cetera. Does the VA monitor any of that? That's a quality measure that the private world does.
I don't have any specific information on that question.
Okay. Can you guys tell me briefly about training that our prosthetic staff at the VA gets, how they deal with these cases? What kind of individuals are training our veterans?
Sure, Dr. Pai?
Yeah, happy to answer that. So we have robust training programs for rehabilitation therapies, whether they're physical therapy, occupational therapy, as well as for certified prosthetists and orthotists. We have the most robust training programs for certified prosthetists or orthotists in the country. We have 15 sites that train 26 trainees annually. The majority of these individuals are recruited then for VA employment down the line. So we can use these programs as our pipeline. For physical therapy, we have 54 training programs, not specific to amputee care, but in general, over 900 trainees, and the majority of 80% of physical therapy trainees are recruited down the line for VA employment.
You know, I get that the world, I was in a physical therapy office in the civilian world in my district, I don't know, 6-8 weeks ago. Very difficult to find physical therapists, as with any healthcare official or position these days. I will tell you, I just am getting more and more and more frustrated to hearing from our veterans that they can't access a system that is built for them. There are frustrations, and it's not just with this particular committee meeting, of access to community care, access overall, and I will tell you, I'm hopeful that in the next administration, the new Veterans Secretary is going to really shake up the VA to determine that we're doing things cost effectively and efficiently, and most importantly, providing quality and timely care to our veterans. Because guys, you can't sell a product that's not working for the people to whom it's supposed to be purchased. So, by whom it's supposed to be purchased. Thank you, Madam Chairman. I yield back.
Thank you, Madam Chair, and thank you to our ranking member, and thank you to the panelists for being here on a very important topic today, taking a look at amputee prosthetic care for our veterans. I wanted to pick up just on what ranking member Brownlee was talking a little bit about, specifically around our women veterans. The GAO report on prosthetics for female veterans, one issue that was raised by veterans was the lack of commercially available prosthetic options that VA providers can use to meet women's needs. And so my question is for Mr. Saslow. What steps has the VA taken to work around these challenges present in the prosthetics market generally and specifically for women veterans? And as a second question, how do these challenges differ by type of limb loss, such as lower versus upper limb loss?
So I'll be happy to start, but one of the things I want to emphasize is that, as Dr. Skolton mentioned earlier, we really do rely on our electronic health record to really look at how we can match the needs of our specific veteran population to how we can best address treating them. One of the things I think is also important to recognize is that we partner very aggressively with our Office of Research and Development in looking at how we can develop those recruitment processes in order to be able to study our female veterans as well as the rest of our population. The one thing I will say is that we recognize that lower limb loss is a much higher prevalence than our upper limb loss, but I think we've done a great deal of research when it comes to how our upper limb loss can be addressed, especially in our female veterans, and I'll let Dr. Skolton talk a little bit more about that.
I would just add that each veteran is treated as an individual, so they are assessed and provided an individualized plan of care. So that, of course, would include which type of amputation they have experienced, as well as what are their goals, what were their recreational activities pre-amputation, as well as things they're interested in doing post-amputation. The VA has also partnered, as Dr. Saslow mentioned, with our research partners, and as a result of that, I did want to reemphasize that the Recover program, which is out of the Minneapolis VA, they have created a 3D printed custom ankle, custom printed foot system, so you can adjust the heel height to accommodate whichever shoe you want to wear. So we've made some significant advancements to provide some unique customization for prosthetic devices for females. There's certainly a long way to go. There's not a lot commercially available, but we're hoping to rely on the innovation of our VA staff to help move the needle forward.
To add to that, at the Denver VA, they're working specifically on upper extremities, so different size hands, prosthetic hands for women veterans. And at the Tampa VA, they're looking at a prosthetic that they call it a brothesis for sports bra for women with upper limb needs.
Okay.
Yes, and I just wanted to add, we recently completed a deep dive into amputee and adaptive driving in the Veteran Experience Office, and two of the things that we came away clearly hearing as bright spots was that veterans truly appreciate the way they're treated as individuals, which is not something we normally hear when we're out doing our research, and also the passion of the providers. So, I mean, I can imagine how it would be pretty easy to be very passionate about this, but that's two of the bright spots, and I think it goes to what you were asking.
Mm-hmm. Thank you, thank you. And if I could, just with the time I have remaining, I wanted to shift gears to rural health and accessibility. Mr. Saslow, I understand the VA's amputation system of care operates as a tiered system with 4 levels of care into which each medical facility is classified. How does the VA ensure that care is consistent across its medical facilities, particularly in rural areas where we know in districts like mine we just have fewer providers?
So I think the really great part is that as the amputation system of care not only has the regional amputation centers, but they also have the polytrauma amputation network sites. And then, of course, we have sites across the entire country where it is a very comprehensive training program that is done every year. We work with not only the facilities, the providers, but we also make sure that there are opportunities for us to learn from our community partners. The other thing that I think we're very proud of is our mobile prosthetics, which we have. It's a rural-funded prosthetics process. We have 15 sites in 11 states, including 32 of our CBOCs. And we're looking at expanding to another 5 sites just in FY25. So I think there's an awful lot of opportunity. We've served over 4,200 veterans using that process with over 6,000 visits.
Okay. I'll yield back. Thank you. Thank you.
The chair now recognizes General Bergman for 5 minutes for any questions he may have.
Thank you, Madam Chairwoman. Thanks for all of you for being here. I'm going to ask a question that I don't expect an answer to, because inside you'll know what your answer is and not necessarily to be talked about now. Is the VA being reactive or proactive on the majority of the time, okay? Because the answer is sometimes you got to be either, each different, okay? But proactivity tends to lead towards less need to be reactive, if that makes any kind of sense. So having said that, Dr. Saslow, how does the VA ensure its prosthetists, that's a tough one to roll off the tongue, prosthetists stay informed about the latest advancements in prosthetic limb technology and innovation?
Thank you for the question. I think, as we mentioned a little bit earlier, there's a lot of training that goes on, not only from a national, but a regional. We also use the concepts of having the 3 regional amputation centers that our physical medicine and rehab have fellowships on. And so we try to make sure that we make training as available as we can. And
I know, I think you probably, because I walked in late, you might have already answered that in some way, shape, or form.
yes, sir.
Okay, so let me ask you a slightly different, from a different angle. Is there any modeling and simulation that is used? If that was asked before, I apologize, but to do what you do.
So, I would just add that we work very closely with the Department of Defense to review all emerging evidence when it comes to amputation care and update our clinical practice guidelines every 5 years. In addition, we partner with DoD to have training opportunities to learn about the latest advancements in prosthetic technology as it emerges so that service members and veterans have access to the latest technology.
Okay, well, I'm not making a pitch for anything in particular here, but each year, the Sunday after Thanksgiving through the Tuesday, but the show floor opens on Monday. ITSIC, Modeling and Simulation Conference, takes place in Orlando. It's a place where obviously a lot of DoD folks go, and there's a lot of innovative technologies there, and good panels, good education. I would suggest if somebody from the VA is not attending ITSIC, you're missing a chance to not have to rely on the DoD for what it might tell you is there. So I would be proactive and send somebody down there. Dr. Saslow, what is VHA doing to get real-time feedback from the amputee patient population to take corrective action when necessary and also address local facility level issues? What kind of real-time feedback chain you got going?
So in addition to the patient satisfaction surveys that we use, we also have a veteran experience that looks at how we can improve and what we've done. And with that, I'll turn it over to Drew because he's got some really great, robust information.
Yes, sir. So each of the outpatient journeys has a stop code that's associated with a particular type of clinic. And the stop code that's associated with amputation, the scores are remarkably high among ease, effectiveness, emotional resonance, and transparency, equity. The lowest score on this for this quarter is 83.5. That's graded on a Likert score of 1 through 5. If they give us a 4, I agree with the statement made, or I strongly agree, then we consider that an indication of satisfaction with that particular piece. 93% overall satisfaction and 89.4% in overall quality. And these are assessed by ongoing. What triggers the survey is a visit to the amputation clinic, and then the veteran receives a survey. It's not 100%, it's not a canvas, it's surveys, but out of this one, this quarter we've received 384 responses from veterans who were seen for amputee issues.
And if I could just add on to that really quickly, we have a process called a completed post-delivery checkout where we look to try to make sure that the veteran actually has the opportunity to tell us that we've met their needs, how their fit is, what their performance is, what their comfort is. And so far that we've been successful in trying to address 81% of those, while our goal is always 100%. We've actually improved our scores of being able to do those evaluations to 81, and we continue to move that forward, sir.
Thank you, Madam Chair. I yield back.
Thank you very much, General Bergman. The chair now recognizes Representative Landsman for 5 minutes for any questions he may have.
Thank you, Madam Chair. Dr. Saslow, in your testimony, you talked about the work that you all are doing to address the gaps in orthotics and prosthetics services, including challenges limited access, including challenges like limited access in the Midwest. So I represent the 1st Congressional District in Ohio, that's Southwest Ohio, and was hoping you could talk a little bit about some of the strategies, just going into greater detail on what you all are doing to address those gaps, what we should be doing, or I should be doing to be helpful. And it's to everyone, but starting with you, Doctor.
Sure, and I appreciate that. As I mentioned earlier, one of the things we are proud of is the fact that we do utilize our mobile prosthetics, but we also have other mechanisms that we're trying to make sure, such as our in-house fabrication at 89 different sites. I don't know, Dr. Pai, if you'd like to also address some of the opportunities?
Yeah, certainly. So our prosthetists will oftentimes use scanning technology to get a sense of the limb that is needed to be fabricated, right? And if they don't have the fabrication lab on site, then they can send that out to a centralized fabrication lab within VA that's in-house. And then the limb is created there. The components, the socket that is fabricated plus the different components are sent back to the facility. and the prosthetist on site can put that together and work with the veteran. They can make adjustments there at their location. They can also do those adjustments in those mobile prosthetic vehicles, what's called MOPOC, that we have at those 15 sites. And then the other thing that we do quite a bit is virtual care. So if, and maybe Dr. Skolton, you want to talk about virtual care from an ASOC standpoint?
So we have, as Dr. Pai mentioned, we've leveraged virtual care extensively in order to not only improve access, but also equity across all areas of the country. So really focusing on our rural areas. We've been able to expand our amputation clinic team, so now there are only 9 VA sites that don't have a full team. Now, a full team would be considered, may include some virtual team members that are beaming in to kind of participate with the veteran and the therapist or the provider that's with the veteran. But we have, we're down to only 9 sites that don't have a fully functioning team. We leverage our other VA capabilities of beneficiary travel in order to allow access for veterans to get to the right level of care. And in FY24, we did perform almost 8,000 virtual care visits, really emphasizing how we're reaching out to veterans.
Considering all that, very helpful. As we look at next year's budget or finishing this year's budget, which will most likely happen next year, as it relates to these gaps, which sound like are being filled or you all have strategies, is there anything that I should be pushing for, or those of us who represent Midwest districts should be pushing for to be helpful?
So I think, as I mentioned, we are looking at the expansion of those mobile sites as well.
The mobile sites
for
being
the FY25, the mobile prosthetics labs.
Yep.
But one of the other things I think is also important is that we really do rely on our community partnerships as well.
Yeah.
Because in those areas where VA cannot provide the fabrication or the prosthetic services, we try to make sure that our community partners are heavily engaged. And the one thing that I think that we continue to work at evolving is how those partnerships can be strengthened in making sure that we are delivering the same type of care through our community partners as we do through the VA. Because we've recognized that there are some gaps in the way that our customer satisfaction exists, and we have opportunities to improve that.
That's great. Thank you all. I yield back.
Thank you very much, Representative Landman. The chair now recognizes Representative Luttrell for 5 minutes for any questions he may have.
Thank you, Madam Chairwoman. Good afternoon, gentlemen. Mr. Seslow, you and Mr. Schulten mentioned the electronic healthcare records and how that information shares, how you're gathering information. Just going to piggyback off of Mr. Landsman's statement and Ms. Budzinski's statement, I think, because there seems to be a shortness when we're dealing with women veterans on the sizing, scope, and scale of their prosthetics. Now, I'm very well aware that the electronic healthcare record system is broken. There's only 6 facilities out of 172 facilities in the continental United States that communicate to each other. So my question is, maybe you can enlighten me on this. I'm trying to get clarification on this as we kind of wade through these difficult waters. How are you aggregating enough data that you can share across multiple sites if only 6 sites are talking to each other?
So I'm not sure where the 6 site information is coming from, sir, but all of our
I just talked to the secretary today.
So all of our sites have the ability to draw data from across the entire enterprise.
And communicate to all 172 sites?
Yes, and the CBOCs as well. It draws from the electronic health record depending upon the type of data you're trying to pull. And so it will go oftentimes by diagnostic code. It will actually look at the age, the demographics as a whole. And so much of our data that we have through the Office of Prosthetics and Rehabilitation, actually we have individuals that work on that data aggregation and help us to drive the care that we're providing forward. And I don't know, Dr. Pai, if you'd like to expand on that a little bit more.
Yeah, certainly. So you're alluding to the disparate VISTA systems that are in our legacy EHR.
It's going away, yeah. Yep, correct.
All of that data does get pulled into our databases, our national databases, that we're able to pull data from to aggregate and to review on a national level. We can utilize that data to provide direction to our clinicians in the field or to our clinical programming.
From Washington State all the way to the Bronx, you guys can communicate without any interruption.
Yes,
This is
sir.
fascinating because I'm going to take what you're telling me and I'm going to go back to Mr. Elnahal and have the same conversation.
As a clinician, so I worked in a facility as a clinician for a number of years. During that time, I could look at, we could be able to pull in records from other VAs through our joint legacy viewer or even through the VISTA system.
Okay. Is there a, for lack of a better term, is there an enclave that exists inside the VA when it comes to aggregating amputees' data set, data information that, because if I understand this correctly, and I have too many friends that are missing limbs, there's a series of stages that go along with once they lose their limb, they get their primary, secondary, tertiary, and then their final prosthetic. Is there an enclave in place that these data facilities, that the VA facilities can access if a veteran is in one of the remote places that says, hey, look, here is the next phase of evolution when it comes to the prosthetics for a below-the-knee amputee. This is what our private industry has implemented into the space. And then you reach out to the veteran and say, hey, look, phase 20 or whatever is ready to go. We have it for you.
Thank you for that question. So we have some capability, but we can't get down to the granularity that you're speaking of about the specific subtype of amputation and the potential prosthetic device or evolution of a prosthetic device that might be necessary. What we do have is we have our Flow 3 system, which allows us to track on an individual veteran level how the process of their prosthetic prescription and then all the way through to delivery and checkout process. So we can monitor that timeline. We don't necessarily have a way to kind of retrospectively go back and identify every veteran with a specific type of amputation that might benefit from a new prosthetic.
You would think in 2025 we might have that capability with artificial intelligence and machine learning. Is this one of those spots that the VA is kind of behind?
So I think when it comes to the use of AI.
I'm just
No, sir.
trying to make this easier on our veterans. It seems like we may be behind the eight ball a little bit when it comes to advances in technology for the VA and helping our veterans out.
And we recognize the use of AI is actually propelling us in healthcare to be able to do a better job, but I don't know that we're there yet.
Okay. Madam Chairwoman, thank you.
Thank you, Representative Luttrell. The chair now recognizes Representative Rouser for 5 minutes for any questions he may have.
Thank you, Madam Chair. I appreciate that very much. So I've got a witness that will come up in the next panel, but my question is for you all now that I have the opportunity. Thank you. It seems to me that in so many cases you have veterans that need prosthetics or whatever the issue may be, that everybody seems to be treated as a number, on somebody's desk. I recognize the inherent difficulties with the bureaucracy, et cetera. But when these veterans come in and they need help and they need care, why don't we have a system where you assign somebody to see their case all the way through? Because you have all these, check boxes. And they check this box, but then they have to wait 8 months to get to this box, and then another 8 months to get to this box, or 4 months, or whatever it may be. It just seems to me like it could be organized in a much better manner, and perhaps it takes more personnel to do it this way. But after all, there are veterans. I mean, you've got a Congress that is willing to invest in these things. Any comment on that or any thought on that? Has that ever been discussed, where you basically have a caretaker in the sense of guiding them through the bureaucracy and make sure that their case doesn't fall through the cracks?
So I think it's really important to recognize that the whole concept behind the amputation system of care really does rely on an interdisciplinary team. And sometimes that case manager for that particular veteran may be a prosthetist, it may be the clinician, but we're also looking at how we can maximize the care delivery and the continuity that you're speaking to using the concepts of care coordination and integrated case management. And so for those patients that are high risk, high visibility, what we're trying to do is to identify someone who takes that ownership of that veteran's care from start to finish. And I don't know, Dr. Pai, if you'd like to address the additional pieces of ASOC.
Care coordination is paramount in this population. And so we want to ensure that we are able to provide our veterans with that type of service, right? Sometimes, and I know our office has worked with your office and the network, and we want to ensure that we're hearing when there are issues like that and there are gaps, because then we want to try and fix them. We did hear from, and I don't know if, Mr. Craig, if you want to talk about the VEO discussion with veterans on post 9/11, but that was something that we heard from veterans that would allow us to do better in the future.
Yes, sir. Our research that I spoke about earlier focused on post 9/11 combat amputees and their experience between DOD and VA and private sector. One of the things that certainly came out of that research was that they do need someone to help them navigate the system so that they don't get put in line behind others who may not have as big a need just based on when they were signed up for an appointment. A number of our research projects for different populations have borne that out. That is something veterans desire.
And if I could just add one other thing, and that is, to your point, I think we do have the opportunity to refine that. I think that as we have other navigators for specialized types of care, like our cancer navigators and things like that, we have the opportunity to refine that even more.
Well, I think there's a number of cases out there that you don't even know about because veterans, they just give up. You know, they at least ought to be able to get their phone call returned when they call. I mean, it's very, very frustrating for every member of Congress. And Madam Chair, I've probably taken more time than I should have been allocated, so I will yield back and wait for my opportunity to introduce our witness.
Thank you very much, Representative Rouser. I now yield myself 5 minutes for any questions I may have. Dr. Saslow, I've heard reports of veteran amputees being denied adaptive prosthetics. How many veterans have been denied adaptive prosthetics in the past year, and what justification is VA providing for these denials? Or Dr. Scott?
Thank you for that question. I'll go ahead and take that. So we certainly don't have the number of, when you say veterans that have been denied prosthetics, we don't have that number. Each veteran is seen in provided an individualized plan of care, and that care plan is based on the veteran's desires to engage in the community and also their medical comorbidities and other psychosocial factors. Our amputation teams are encouraging veterans to participate in recreational activities, and we are able, with our prosthetic regulations, to provide any device, provided it's FDA cleared, that is clinically indicated for a veteran. And while that development of that individualized care plan allows us for those items, even though they're recreational type items, to be clinically indicated to enhance their community participation.
So my staff has been in contact with a veteran who's been waiting all year for a prosthetic leg. He was told by the Nashville VAMC that his delay was due to a backlog of 4,000 prosthetic devices. Do you think this is acceptable?
I don't.
What immediate steps is the VA taking to address this significant backlog?
I would be happy to get some information about that specific veteran case.
Thank you. Is the VA leveraging community care and third-party vendors to alleviate this backlog? And is there anything preventing the VA from outsourcing more effectively to ensure timely prosthetic care and access?
I'm happy to answer that question. While I specifically don't know, or I can't answer specific to you said Nashville or Tennessee backlog, but in general, we do leverage community vendors, providers that are prosthetists. We work very closely with them. About 2/3 of prosthetic limb fabrication is provided out in the community. And our clinical teams, the amputation team that Dr. Skolton has described, they work in concert with those community providers. Oftentimes, when a veteran is there getting their prosthetic limb or getting their therapy, our clinical team has beamed in with telehealth. so that they can ensure that the veteran is getting the care that they deserve.
So to better understand the scope of this issue, I'd like a list of every VA medical center that currently has a prosthetic backlog. To be specific, I would exclude glasses, hearing aids, scleral shells. I'm speaking of limb prosthetics, arms, legs, hands, etc., broken down by item type by December 20th. Dr. Saslow, you mentioned earlier about the whole health approach and the annual assessment. We know that the majority of amputees come from vascular disease or peripheral vascular disease, or peripheral arterial disease, which could be diabetes or other types of peripheral arterial disease or PAD. We also know that the life expectancy or mortality once one has been diagnosed with PAD is quite significant, above 50%. So my question is, given that you have a whole health approach and an annual assessment, is the VA screening for PAD with a simple device such as an ankle brachial index test?
Yes, thank you for that question. I think one of the examples I think is really important is what we're doing with regards to our remote temperature monitoring and our sensory podometric smart map. That allows us to actually identify veterans that are at risk. We also have things called the siren socks or the Orpix insoles. So we are taking every advantage that we can to identify early diagnoses so that we can do prevention. One of the things that we've been able to be successful with is actually reducing the number of ulcerations based upon some of these uses by about 15%. We've actually seen a reduction of about 37% in our amputations and admissions to hospitals of about 10%. I think it's really important that this is just one set of tools that we use when it comes to addressing peripheral artery disease.
In the 2019 RAND report, and this is coming off of some of the other questions, the U.S. Army noted that for all individuals sustaining combat amputations, the goal is to return them to the highest level of activity they wish to achieve. In contrast, the standard of care at the VA focuses on returning amputee patients to a community ambulation level. And I certainly understand that with the majority of amputees in VA care being elderly and from vascular disease. But it enables them to perform basic activities of daily living, not to the highest level of activity they wish to achieve. Shouldn't the VA hold itself to the U.S. Army standards, particularly for post-9/11 service-connected amputees, to ensure they can function to their highest potential? Or do we need to legislate that there is a priority given to returning young amputees back to a full life, daily activities?
So we completely agree that we want to return people to the full extent of their activity of daily living, which is one of the reasons why we really have been trying to push for our veterans to get the equipment that they need to be as flexible as they can be. And one of the things that I think reflects that is the number of adaptive sports programs that we have that helps to highlight what the capabilities are for those veterans that may be seeking to improve their quality of life.
Thank you so much. On behalf of the subcommittee, I want to thank all of you for joining us today. You're now excused, and we will wait for a moment as the second panel comes to the witness table.
Thank you.
I would now like to introduce the panel two witnesses. Testifying before us today, we have Mr. Jose Ramos, Vice President of Government and Community Relations at the Wounded Warrior Project. We have Ms. White, Chief Strategy and Programs Officer at Amputee Coalition, and then I'm going to recognize Representative Rouser to introduce our third witness.
Well, thank you, Madam Chair and Ranking Member Brownlee. I greatly appreciate you having this hearing today. It's a great honor for me to introduce Mr. Matt Brown. He's an Army veteran that currently resides in my district. It's an honor to represent him. Mr. Brown served in the United States Army as a member of the 82nd Airborne, assigned to Fort Bragg, or what's now known as Fort Liberty, North Carolina. After active duty, Mr. Brown continued his service in the Maryland National Guard before moving to Wilmington and founding Energize Group Dental Marketing, a very successful businessman. Today, the committee will hear firsthand from him about his very, very frustrating experience dealing with the Fayetteville VA Medical Center while acquiring trying to acquire his prosthetic. My team and myself have worked very diligently to get his case resolved, and it almost took an act of Congress just to get him elsewhere to actually receive the prosthetic that he needed. He will go into much greater detail, but it really is a very disturbing set of facts that he reveals, and he's not the only one. He's representing probably thousands and thousands of other veterans who are facing the same issue. So I greatly appreciate you allowing him to come and testify. I appreciate it much. And Mr. Brown, thank you for your service. Thank you for your tireless efforts to advocate for not only yourself, but all the veterans that need the help and that they deserve. I yield back.
Thank you, Mr. Ramos. You're now recognized for 5 minutes to deliver your opening statement.
Chairwoman Miller Meeks, Ranking Member Brownlee, and distinguished members of the Health Subcommittee, thank you for today's hearing. I want to begin by saying that every day Wounded Warrior Project has the privilege of working with our VA partners, and we get to see the amazing work they do and the dedicated staff who are committed to caring for our nation's veterans. Our organization has been serving wounded warriors across the country for more than 20 years, interacting with thousands of warriors daily and helping them lead healthy, fulfilling, and empowered lives. Since the beginning of the global war on terrorism, Wounded Warrior Project has been at the bedside of just about every single combat amputee, close to 1,800 of us. Today, we continue to serve these warriors through our adaptive sports and independence programs, just to name a few. While I serve as Vice President of Government and Community Relations, I would like to share my story as an amputee. In 2004, while serving on my third combat tour as a Navy corpsman attached to a Marine sniper team, I was severely injured when a rocket hit our position and instantly severed my left arm. Shortly after my recovery, I was fitted with a prosthesis. I felt whole again and quickly became dependent on it or some other type of adaptive device to live a fulfilling life. I have tried 3 times to transition from DoD to VA for my prosthetic needs. And 3 times, I have left believing that my care is better left to DoD. I've experienced getting wrong prosthetics, a right hand when I'm missing my left hand. VA has told me that I'm better off going to DoD for my care. VA providers not knowing about the latest cutting-edge technologies, and VA changing its policies to make it harder to get adaptive devices. Roughly 20 to 30% of post-9/11 combat amputees decide to stay with DoD for their prosthetic needs. And while many have successfully transitioned to VA, relying mostly on community providers, too many have also experienced challenges, and at times, disappearances trying to use VA. You would think that someone like myself, with over 2 decades of being an amputee, who understands the system better than most veterans out there because of the work I do, that I wouldn't face or that would fare off a bit better. On this last attempt, which started in late 2022, I decided to go all in. I did so because my prosthetist, who had been my prosthetist with DoD for the last 18 years, became a VA community provider. So I figured it should be seamless. From the start, I felt like I had to fight what I truly needed, something I've never experienced at DoD. I felt like the system was designed to work against itself and against my needs. For example, I dropped off a broken hand in late 2023, and it took 6 months to get it back. I finally received a functionable hand back in June of 2024. While I waited, my other 3 hands broke down, and now I'm choosing to go back to DoD for my replacements. I can't wait months. Not having a working prosthetic is not simply impacting physical abilities, but as you've heard before, it impacts mental health too. I firmly believe that VA is committed to serving our nation's veterans, and I see that every single day. But for VA to truly be the best in the country, there are areas where improvements are urgently needed, especially when it comes to the care of our most severely disabled warriors. I believe that VA should be the world's premier place for amputee care and prosthetics. However, my personal experience tells me that there's still room for improvement. As we highlighted in our written testimony, VA can take at least 4 steps to become best in class for amputee care. First, recognize the unique needs of amputees rather than grouping amputees and prosthetic limbs with other prosthetic users, such as those who use hearing aids, wheelchairs, or even hip implants. It's just different. Second, increase the hiring of prosthetists and expand in-house fabrication capabilities within the VA to ensure that veterans get timely, expert care. Third, promote and support holistic, healthy lifestyles for amputees by providing necessary adaptive equipment to help veterans stay active without forcing them into rehabilitation programs that may not be needed. And finally, provide increased funding to support and expand innovative programs like the Mobile Prosthetic Orthotic Care Program to reach a larger population of amputee veterans. The VA has struggled to recognize that there is a large number of younger, more active amputees demanding more of their prosthetics. Veterans deserve the best care, and with the right investment and commitment, the VA can and should become the global leader in prosthetic care for amputees. I thank you for inviting me to testify today and look forward to answering your questions.
Thank you, Mr. Ramos. Mr. Brown, you're now recognized for 5 minutes to deliver your opening statement.
Thank you, Chairwoman Miller and Ranking Member Brownlee. For inviting me to testify about my long and frustrating experience with VA prosthetic services at Fayetteville, North Carolina VA Medical Center. I am a U.S. Army veteran.
Hey, buddy. Sorry. You're 82nd Airborne. You're the toughest son of a bitch in this room. All right? Hey, we're here for you, man. Suck it up, all right? You're amongst friends. Let's hear it.
I am a U.S. Army veteran who enlisted in 2009 and sustained traumatic brain injuries and spinal fractures from an airborne training operation at Fort Bragg, North Carolina. I left active duty service in 2011, transitioning to the Maryland National Guard. I was honorably discharged in 2015. I have always been very active, running, doing martial arts, scuba diving. I was diagnosed with bone cancer in May of 2021. My life was forever changed when I was still a young man, a family, and a thriving business. Much of my self-worth was derived from my physical abilities. To the extent of the cancer, my concerns concerning about having my surgery at the VA Center, I was given a community care referral to Duke Medical Center in Raleigh, North Carolina. In summer of 2021, my left leg was amputated above the knee in August of 2021 at Duke. After the surgery, I was in a wheelchair for 7 months. My first VA treatment appointment was on November 18th, 2021. VA claims they gave me a martial arts prosthetic within 28 days and a state-of-the-art leg system within 53 days of this appointment, but neither of those worked. I learned later that remaining in a wheelchair post-amputation for as long as I did can inhibit physical and mental recovery. I had no idea it would take the VA 2 years to get me a proper prosthetic. I would have to advocate aggressively for myself at every turn. Eventually seeking help from Representative Rouser, Senator Tillis, the Independence Fund, and this committee staff, my experience with the VA over those 2 years were bewildering and demoralizing. The staff at the local VA hospital consistently failed to communicate well about my care, follow through on my care coordination, and expedite requests for prosthetics. All of the community vendors who responded to the VA request to produce the proper fitting leg socket for me did their best, but some told me the acquisition process at VA was slow and sometimes they would not get paid promptly by the VA. This would only add to the stress of not being able to resume my normal activities outside of a wheelchair. In October of 2022, I heard about a special socket the VA had provided to another amputee, the Quattro Variable Volume Socket. Given my level of physical activity and the changes in blood flow and residual limb, I thought this system would be my answer. I asked the VA to obtain one, but they never followed through to acquire it. The request sat idle and eventually expired. I had to start all over again. I continued to work with a local vendor to obtain a properly fitting socket. During those months, I was using a prosthetic ankle. I visited the vendor for routine maintenance in September of 2022. The vendor told me they had to repossess it because the VA hadn't paid them. I left the vendor without the ankle and had to temporarily use an older ankle that was not flexible for the next year. VA continued to pursue the same types of sockets. I continued to tell the VA that I needed a different type of socket, basically the Quattro. This Groundhog Day process was extremely frustrating for me and my family. I was stuck in a wheelchair for 6 months and missed out on many personal activities. In October of 2023, I was so frustrated with VA Prosthetics after a socket they acquired from a vendor broke while I was overseas. I contacted Congress Rouser's staff for help. They tried to get VA moving, but Congress was still slow. After 2 months of congressional inquiry, I reached out to the Independence Fund's casework team in Charlotte. Their team and Congressman Rouser's staff joined up and pressed VA for answers. In December of 2023, VA finally agreed to shift my prosthetics care to Richmond, Virginia. I was assigned to a VA prosthetics doctor there. He assessed my needs for a different type of socket so I could get out of the wheelchair and travel more easily for my business and participate in sporting activities with my wife and friends. The Richmond VA doctor worked with me and local vendor to get me an interim that fit well. But it wasn't until May of 2024 that VA finally purchased and delivered the Quattro socket I'm using here today. I have lost 34 pounds since getting the socket. I'm a new person today. This only happened because of continued pressure on VA from Congress and the Independence Fund. Looking forward, it's clear to me that VA needs a deep dive into what they address and process everyday amputees' needs for prosthetics, especially ones like mine, and deliver them timely. The entire experience can be overly bureaucratic, sluggish, often impersonal, and sometimes uncaring. I know VA has testified that the cost of these recreational limbs is a concern, but very honestly, these experts don't realize what it's like to be confined to a wheelchair, unable to swim or run, carry your child, and then ignore unseen costs, long delays like mine, like mental health anguish I went through, and the related costs VA paid for additional mental health visits I needed over these 2 years. The VA has also testified that all these services are already being provided, yet I and other amputees are proof that commitment is not being honored and followed by local VA staffs and supported by a responsive acquisition system. There are lifelong future cost savings for VA when veterans can obtain the prosthetics they need to live active, fulfilling lives. We are not looking for special treatment. We just want to live our lives as independently as possible. I appreciate the time you have given me today and look forward to your questions.
Thank you, Mr. Brown, for making the trip here to Washington, D.C. to share your story and your testimony with us. Ms. White, you're now recognized for 5 minutes to deliver your opening statement.
Good afternoon, Chair Miller Meeks, Ranking Member Brownlee, and the distinguished members of the VA Health Subcommittee. My name is Ashley White. I am the Chief Strategy and Programs Officer for the Amputee Coalition, and I am testifying today in that capacity. Thank you so much for this hearing and this opportunity. The Amputee Coalition is a 501c3 organization established in 1986 to provide support, education, and advocacy for the over 5.6 million individuals living with limb loss or limb difference in the United States. The Amputee Coalition provides information, referral, healthcare navigation services, peer support, and community engagement programming through its operation of the National Limb Loss Resource Center, which is funded through a cooperative agreement under the Administration for Community Living and the Department of Health and Human Services. At the heart of the Amputee Coalition's mission is our peer support programs. The organization was founded from a peer support program. Our goal is to make sure that no one goes through this journey alone. We believe that support comes in many forms and can make an incredible difference in recovery and rehabilitation. Through an annual contract with the Department of Veteran Affairs, our organization provides technical support, print and digital resources, certified peer visitor training, as well as train the trainer training, and helps facilitate the Amputation Systems of Care peer support program. No one is in a better position to understand the experience of living a life with an amputation or supporting a person with limb loss than someone who has traveled that journey. A well-trained peer can offer encouragement and information. An individual navigating the start of their own journey can better understand, absorb, process, and accept. A peer-reviewed study published in 2022 noted that peer support interventions showed promise in addressing suicide risk. As noted in a recently published GAO report, over 93,000 veterans living with limb loss receive care through the VHA annually. Beyond combat-related injury from serving in the armed forces, limb loss can also be the result of complications due to diabetes and peripheral arterial disease. The VA reports that most of its patients living with limb loss treated by amputation systems of care suffer from one of these conditions. The previously mentioned GAO report also highlighted, as Chair Miller-Meeks mentioned, and as others have testified today, that the amputation specialty clinics through which many of the veterans receive limb loss, receive care related to their limb loss, are staffed by an interdisciplinary team. This interdisciplinary team model is the gold standard and one that we at the Amputee Coalition wish all Americans facing limb loss could have access to throughout their continuum of care. Recognizing that some veterans living with limb loss may experience mobility challenges, virtual amputation clinics also exist to access care from a VA medical center. This opportunity provides veterans living with limb loss the ability to connect to a provider from various locations, including at home, a VA clinic, or a community prosthetic partner. This is also not the standard of care offered to most, available to most civilians, and we commend the efforts to the VA to make care more accessible for those living with limb loss. In acknowledging the successes of the VA care model, it's also important to note some of the challenges and potential areas for improvement. Healthcare access challenges faced by individuals experiencing limb loss in rural America continue to be a concern for the Amputee Coalition. The GAO report confirmed that 28% of Medicare beneficiaries who received amputations live in rural areas, but only 20% of all Medicare beneficiaries live in rural America. While the report did not provide this data for the veteran population, one cannot ignore that rurality plays a role in access to coordinated health care. While the VA employs many certified prosthetists, orthotists for its various clinics, much of the prosthetic care received by veterans is still provided by community O&P providers. The reports we receive from veterans highlight differences in communication processes between clinics within the VA and those in a community setting that vary from facility to facility. Creating more streamlined, coordinated channels of communication between community providers and the VA clinical teams is vital to ensure that care remains coordinated when an individual is receiving prosthetic services outside of the VA setting. Our partners and provider groups also representing the orthotic and prosthetic field have also expressed their concerns about the orthotics and prosthetics workforce pipeline, and it's my understanding that the National Commission on Orthotic and Prosthetic Education is in the process of initiating a study to look specifically at those workforce shortages. While the VA remains an attractive employer for CPOs, the Amputee Coalition is concerned with the recent reports of attrition that are coming out of these Masters of Orthotic and Prosthetic programs, especially since there are only 13 programs at graduating master's level O&P providers. In closing, the Amputee Coalition expresses its gratitude for the opportunity to be a trusted partner in serving our nation's veterans every single day. We value our partnership with the VA and are committed to supporting efforts to improve prosthetic care and the mental health and well-being of those veterans who have or are at risk of experiencing amputations.
Thank you, Ms. White. We will now proceed to questioning. As is my protocol, I'll defer my questions until the end. I will now recognize Ranking Member Brownlee for 5 minutes for any questions she may have.
Thank you, Madam Chair, and thank you all for being here. And Mr. Brown, thank you for your service to our country and the courage to come up here and share your story. I want to understand the period of time that you kind of went through this horrible experience. It sounds like it sounded to me like it was a 2-year period from the time that you wanted to get out of that wheelchair and get a prosthetic to the time that you finally got one that worked for you. Is that roughly right?
Yeah, it's pretty accurate. It was about 2 years. There was, it was like there's a loyalty more to the bureaucracy than the end user, the patient. And I was very, like, I'm the person using it, and it's like you get up in the middle of the night to go to the bathroom, and your leg falls off in the bathroom, and you fall, and you say, this thing keeps falling off in public, it's falling off, and they replicate and do the same socket all over again. And I knew what my problem was. I did my own research, and I said, this is the solution. I knew another veteran who's a friend of mine in Colorado who got that socket, and I wasn't able to. And the whole time I was asking for a running blade so I could start running, so I could start exercising again. I'm a really active guy. There was a lot of things, and it took about 2 years total from beginning to end to get it. I just got it this past June, so I'm still...
And the running blades, did you get those?
I have the running blade. One issue with the running blade is you have to do a running clinic to learn how to run, And I still, since I've got my running blade, haven't been able to get to a running clinic. They were like, there's 2 we could possibly send you to. One's in Washington State, and one was over here. And there wasn't really a way to facilitate training me and teach me how to run. So I said, here's this item, but there's no support on how to use the item. So I'm kind of using my personal trainer at home to try to figure it out on my own, which I don't know if is the safest, but I want to run with my wife. So.
And so how many prosthetics were you given before you got the one, I can't remember what the name of it, but it's what? The Quattro?
Yeah.
Yeah, how many tries?
The socket, I don't have the number in front of me, so I won't be inaccurate, but if I had to guess off the top of my head, we probably had 10 to 14 tries at the socket, but it was all different variations of the same attempt.
But you had, I mean, sort of, at least 6 months into it, you had done your research and you knew what was going to be best for you, and you still had to go through a lot of.
There was a lot of not understanding my needs. Like no one, like they talk a lot about team care when they're up here. The team, I'm not sure. I've never saw the team. I saw a person that was a prosthetist who was 70 years old, who was out of touch and didn't care. He did care, but he just didn't want to read through it. And the one problem I had was I'm a Brazilian Jiu-Jitsu black belt. I train a lot. I wrestle. And when I would come off the mats, my leg wouldn't fit anymore. I said, I need something I can adjust. And a friend of mine that is a black belt, who's also a veteran in another state, got this from you. I would like this. And it was, what we actually found out was the purchase order actually had been cut to the vendor, and it sat there for a year and no one told us. And then I called the vendor, like, can you help me with this? Like, we had your purchase order for a year and now it expired. So at some point it got authorized and we had not even known.
Thank you, and again, thank you, Mr. Rouser, for getting involved and making it happen. Sadly, I apologize for the VA and their inability to satisfy you as a veteran and as an important patient in their care. So, but again, thank you very much for being here. Ms. White, I wanted to ask you. I absolutely am a firm believer in peer support programming and peer support groups and how effective they can be for veterans with a variety of different kinds of issues. I'm just wondering, I tend to spend a lot of time on women because I don't feel like women veterans get the attention that they deserve. So I'm wondering how many women, have you served? And do you believe that the women that you have served, that a woman-to-woman peer group is the best option moving forward?
Thank you for the question, Chair, Ranking Member Brownlee. With respect to the number of women served by the Amputee Coalition, our support programs operate through the amputation systems of care. So about 14% of the individuals who come directly to the Amputee Coalition's Information Referral Center, so those are direct calls to us, about 14% of those are veterans, and only about 2% of those are women. So a very small,
veterans and non-veterans.
And sorry, yes.
Yes, I got it.
And so if you look at those numbers that are directly served by our organization, not through the partnership that we have with the Amputation Systems of Care, it's a small number. But I do believe that many women are going to community support groups. So there are nearly 300 community support groups that we help facilitate. So they're affiliated with us, but they're actually operated by individuals who live in those communities. And I believe that many women are going to those community groups, and they are finding support, whether that's through a civilian who has a similar level of limb loss or a person who has a very similar experience to them and may also be a veteran. So I think they have access to both support groups in their communities as well as through the VA system.
Very good. Thank you for that. And thank you for what you do, because it sounds like what you do is really important to servicing our veterans and having success with limb loss and all the wraparound issues and support that they need to have the highest quality of life that they certainly deserve. So thank you for that. I'm over my time. I apologize, and I yield back.
Thank you for yielding. The chair, and thank you, Ranking Member Brownlee. The chair now recognizes Representative Luttrell for 5 minutes for any questions he may have.
Thank you, ma'am. Mr. Brown, Mr. Ramos, at this level, we try to unpack the suitcase on this. We understand the varying levels of difficulty trying to get the quad for your leg, and then your arm, obviously. Here's the tricky part. Who did you call? Who said no? Where did it go from there? Because I would like to have names so I can personally address this issue at the granular level. Veterans are veterans. We just love to come just to say things are going bad. I got it, but we need to know exactly where we need to touch this. So I'm going to ask both of you, when you talk to at what level who you're speaking with, and where are they going, and where is it dying? Where are the barricades and the barriers existing, so we can get in there and try to clean it up? Mr. Ramos, you can go first, and I'll go to Mr. Brown.
I think you asked a really good question. I think the challenge is there isn't a single person that you can really reach out to be very honest with you. I think the system collectively, the way VA defines prosthetics and amputees generally, sits under PSAS, or the Office of Prosthetic and Sensory Aid Services. And that truly is more of an acquisition logistics and procurement process. And it's funded in that way. So the prosthetists and prosthetic limbs all reside underneath that. And one of our recommendations here is we got to kind of separate and stop talking about prosthetics as the same
Hearing
as
aids and eyeglasses.
hearing aids,
Yep, gotcha.
glasses.
Yep.
Right, so I think that's the challenge. I think for the both of us, reaching out to our providers, our community providers. I mean, a similar story for me was a lapse of time as it relates to the purchase order being submitted and not being sent to the provider, not knowing.
It seems like a series of communication breakdown, because you're I don't mind, I've got a brain for it here, but your system was sitting there waiting to the paperwork was waiting to go, and it died on the vine, correct?
Yeah, the communication breakdowns, I couldn't have hoped for a better question from you, Representative Luttrell. So my local VA, this is gonna sound unbelievable to you, that the phones have been broken for several years. I can't call in and make an appointment. I heard a lot of talk today about satisfaction scores from the VA officials, and you can make studies and package data up and paint a picture. There's a KPI or standard that all of us in this room, civilian, veteran, any industry value. It's universal, and it's a Google rating. And the Google rating for my facility is like 3.5 stars. And if you read those reviews, for years, we have been complaining with no feedback loop to help that we can't call in and make an appointment. We have to drive in to make an appointment. I challenge all of you, take your phones out, Google Wilmington, North Carolina VA Hospital, and read the reviews. You can go back 4 or 5 years, and everyone's on there complaining, we can't call in. To this day, I still can't call in and make an appointment, I have to drive in. So a fundamental of patient care is communication. And if we take this KPI, like we can package up all these KPIs, right? But that's the standard of excellence for the world. I just challenge you in your districts, go look at the Google ratings and read the reviews. They're generally not good because of this. And then on the level of the granular level, my prosthetist, he verbally told me, there needs to be 5 of me here and there's 1. And I'm 68 years old. And his name was Thomas Ray. Generally a nice guy that cares, but he wasn't equipped to handle this. And his boss, Damon Deloche, was just out of touch with the whole process. But on the fundamental level, when I was waiting for my prosthetic, I couldn't call in to get a status update. Every Thursday, the prosthetist visited my local VA center. I would take my wheelchair, throw it in my truck. I'd only been amputee a few months now. I would drive to the VA center, sit in my wheelchair, wait in the lobby to hope that he would walk past me to ask for an update. If we can't handle the fundamentals of patient communication, like calling in, and I'm kind of a little bit of an aggressive guy with some stuff, and I figured out who the director of that building was. I found her picture, and I waited around for her. And her name was Debbie, and I addressed her. I said, "You're the director, right?" She said, "Yes." I said, "The phones are broken." She goes, "Oh," I quote, "I know they've been broken. They've been broken for years. I just don't know who to call."
Okay, next steps for me is going to find out, because there's multiple sites, so I need to find out who the process is calling at the next level and where that goes to get everything activated and how it comes back down inside the organization to clean up this problem set. And the gentleman that I'm going to discuss that with are sitting directly behind you, which I think you should have gone first in this hearing. That would have given us extra ammunition, if you will, to have discussions with the VA staff, or VA leadership. But thank you, and Madam Chair, I yield back.
Thank you very much, Representative Luttrell. The chair now recognizes Representative Rouser for any questions he may have.
Thank you, and I'd be happy to yield some more time to my colleague, Mr. Luttrell, if he wants to follow up. You had a good line of
I
questions.
could sit here all day. I'd like to dig in with you, Mr. Brown, because when your case was moved out of the Wilmington VA, where does that land? At what site?
So we ended up at Richmond, Virginia.
So Wilmington goes to Richmond.
Yeah, so we moved out of the Fayetteville or Vizen 6 to Richmond, and the doctor who received me was Dr. Joseph Webster, who's an awesome clinician. He was an angel for me. He got me my leg back. He was compassionate. He was awesome. It was the opposite experience of what I experienced in Fayetteville, but we had to move my care all the way to Richmond, Virginia to get me past this 2-year ordeal.
Can you explain to me at a kind of a deeper level why that? Because the people behind you are listening, and I need them to hear this, which I'm sure they've heard it multiple times, but they're going to hear it right here in front of Congress. So I want to know why and where not most of the communication, but the movement of taking care of our amputees at Wilmington seems to be lost. And then you have to go to you have to go to Richmond.
Yeah, go to Richmond. So just to give you an idea, like the level of distrust that developed so rapidly, I actually had to start like recording my doctor's appointments to document things because of me requesting things verbally and not having them. And what happened is I would request something. So I'd wait a long period of time for an appointment with a prosthetist. I would request something, and then he would say, "Oh yeah, we're working."
Do you have the paperwork that you received from the VA that says why this got canceled with a name on the bottom of it?
No.
That's tragic.
Yeah, I never really could, like, so I was asking the prosthetist, like, when am I going to get this quattro socket? And every time it was a kick the can down the road, and it was a very vague answer. He was the only prosthetist for our region. He swore there needed to be 5, there was only 1. He went out with COVID for 3 months, and he finally called me back one day, and he said this to me, and I work in healthcare in dental, so I'm very familiar with HIPAA laws. My company handles a lot of personal information, and we're really compliant with that. He said on the phone to me, he said, "Matt, I'm home with COVID, and my dining room table is covered with patient paperwork that I'm trying to get through while I'm out sick with COVID." And my first reply was, "That's a HIPAA violation. My information cannot be in your home." It's like there's a deliberateness you do things with when you want to achieve. And what I will tell you is in Vizen 6 Fayetteville system, that deliberateness doesn't exist for excellence. And just look at the Google reviews. We give the reviews. It's all under 4 stars.
Mr. Ramos, your turn.
I think this frankly highlights the necessity to really evaluate what DoD does versus what VA does, and I'll tell you why I say that. Unfortunately, my brother in arms here doesn't have the luxury to be next to an MTF Center of Excellence to just walk in and get the assistance they need, right? And we should strive collectively to ensure that the VA is the Center of Excellence. And I'm not saying we need to build a Center of Excellence in every single district, because that's not possible. There's not many amputees. But dang it, every single active duty or post 9/11 combat veteran will tell you exactly if they want to go to the best care for amputee care, they're going to fly to BAMC, they're going to fly to Walter Reed, or they're going to fly to the Center for Interpret, right? And by the way, they're going to pay out of their own pocket to get there, but nonetheless, and VA should have the exact same thing, and we just don't.
When the question is asked why the VA doesn't have the same model as the DoD, what is the response you get from those that you're engaging with?
So we talk a lot about the ORIC system, or kind of the amputee system of care. I'll tell you, until I started working with a project, I didn't know it existed. Right? We have 7 sites, and I think collectively the culture is we have the systems in place. And I'm not saying that it isn't in place for maybe older geriatric patient population. It's just not responsive to a young, active population who is beating the crap out of their prosthesis and trying to live a fulfilling life. When I turn 70, I'm still gonna continue to do what I do. I have 4 hands because I break them fast. I break them fast because I'm an active individual. And their system is not responsive to meet my needs, to meet his needs. It's just not designed that way. Because
how long can you stay with the DoD? Do you ever have to transition away from DoD to VA?
You do not. I do fear part of why I've come to the VA system to give it a try is I fear that at some point DoD says, hey, you know what, you're a veteran, go to the VA, go to VA. The answer is DoD looks at us also kind of a way to ensure that they continue to maintain their expertise in dealing with combat patients based on what's happening across the globe. So we have not been asked to no longer come back, but that's always been a concern. So right now, as far as I know, now it's a different situation for him because he is not a service-connected combat disabled veteran that went through the system. But I do not, and that's why I'm going back to DoD, to be very honest.
The gentleman.
Yield my time.
Yeah, my time's expired.
Thank you. Thank you, Representative Trell and Representative Rouser. The chairwoman now yields herself 5 minutes for questions she may have. Mr. Ramos, and I think you brought this up, but how did your experience with the DoD prosthetic care compare to care provided directly by the VA, and were there noticeable differences in quality or timelines?
So I think what would be helpful is to kind of maybe give you a comparison of the two different experiences and systems generally, right? At DoD, the prosthetist and the clinic or the amputee care clinic are jointly co-located, right? So when I go talk to my primary provider, my prosthetist is there or easily accessible, and we can talk about here are my challenges. Okay, got it. Here's a prescription, and then go and execute. Now, if I need something that's modified on the spot, they can build out. If it's something that needs to get sent out to either rebuilt or new, they do that right there. And then I get it in a matter of weeks, right? With VA, for example, the VAMC here in DC, they're not co-located. As a matter of fact, two complete different spaces. I first have to make a visit with my primary clinician, and then get that prescription approval that then gets sent to my community provider. Now I have to make an appointment with my community provider, drive down to Bethesda, and actually go through the process of kind of working with the prosthesis. That individual then now has to wait for the purchase order to come in to them so that they can go and execute on the actual prosthetic delivery or fixing. And then from there, I have to either go back to the community provider and make sure that it's the right prosthetic in this case, because I've experienced having the wrong one been delivered to me now. And then eventually, kind of that's what the process looks like. So it's really a almost instant fixing of, addressing need, approval of, and execution versus coordinating different meetings, different appointments, getting approvals, waiting, and then eventually getting your prosthesis.
Yeah, and that difference in the care that you receive and you perceive may in fact be a difference in mission between the DoD and the VA. And certainly we've heard a lot about the populations and the type of population that we're dealing with as a veteran population, as an active duty DoD population. So to me, what I'm hearing loud and clear is that there needs to be a segregation of prosthetic limbs from other sensory type of prosthetic devices, i.e. when you were here, I was adjusting my prostheses, my glasses, but glasses, hearing aids, scleral shells, facial implants, even wheelchairs, these types of devices need to be segregated and have a amputee prosthetic office that directly deals with that within the VA. And then second, perhaps also segregating the populations. And no one wants to say that. It's not politically correct to say that. And although I'm almost 70 years old, I would say I'm an active 70-year-old. But nonetheless, a person's needs who is retired and not working is certainly different than a person who is working and raising a family and trying to support a family. So, Mr. Brown, did anyone so you were diagnosed with the cancer, you're at the VA, you know you're gonna have treatment for your cancer, you're gonna have an amputation. So did anyone from the VA's amputation system of care team engage you before your amputation or how long after your amputation?
So earlier, there was a conversation about proactive versus reactive. Me and my wife are really proactive people. We knew this was coming. We knew for about 3 months my leg was being amputated, and I proactively contacted the VA. No one reached out to me. And the extent of the team experience they speak of was, I went there, sat down with that prosthetist, and what I was told was, it was a very short conversation. I was sitting in his chair, maybe 5 minutes. The VA is world-class when it comes to prosthetics, was the claim, and that whatever you need, you're gonna get, and there's no problems. And it was a great expectation, and I felt good about our decision. So then the amputation happened, and then it was kind of like, the best analogy I can use is it kind of felt like a used car salesman. I was told this awesome, rosy story, and then the moment it was time to facilitate care, I had to wheel myself to the VA on Thursdays to hope to bump into this individual to get an update, and I was never given a timeline or expectation, and there was no team experience.
Yeah, I can certainly understand that, waiting for the stump to heal, and there's a ton of questions I would have about all of this process. One of the things I also heard, and let me say that having been in the military, both enlisted as a nurse, as a doctor, worked at the VA, relatives at the VA, family members, I can assure you that the people behind you haven't heard of your story, because that's how bureaucracies work. And what happened at the Wilmington VA probably stayed at the Wilmington VA, instead of that being ratcheted up the chain of command to where the people who can actually implement policy changes and make those individuals work to the best of their ability don't get that information. We also heard from Dr. Saslow and Dr. Skolton that the scores that were received and feedback reports had very high scores. 88% clinical prosthetic patients at the Fayetteville VA Medical Center are happy. And as I listened to that, if someone didn't take the proactive approach to go and study what socket, what terminal, what prosthetics, if you're a woman, do you have a prosthetic that's going to adapt to the different type of shoe that you're wearing, to the different type of activities that you're engaged in, whether you're working or non-working, whether you're lifting children. If they don't take the proactive approach to do that, how do they know what's available? And if in fact they're getting state-of-the-art care, how can you determine whether or not you're satisfied? All you can determine is you're satisfied with what you were given, but not what the range of options are available to you, or even if there's adaptive prosthetic devices. So based on your experience, Mr. Brown, and conversations you've had with other veteran amputees, do you believe that statistic accurately reflects the quality of care and trust at Fayetteville, or the experience other veterans may have?
No, I don't think it's anywhere near accurate. I sit in the waiting rooms with the other amputees in the prosthetics department, and the amputee community, the veteran community is small. The amputee veteran community is smaller, especially in our region, and it's real easy for us to find all each other. And I started like a little WhatsApp chat with all my fellow amputee friends and asked them, how long are you waiting for this? How long are you waiting for that? And the experience is pretty uniform. When you lump in major limb amputation with eyeglasses and compression socks, it's easy to get a positive review of questions you loaded up to get the metric you want as a survey you sent. When you're asking someone about compression socks versus a complex item like a leg that creates your ability to be mobile. When I heard in FY24, the satisfaction rate was like 95%, that is not accurate. And going back to the Google rating, like I mentioned earlier, that is the world standard for excellence. And I personally started looking at the facilities in my area, and they all were well below 4 stars, most near 3 stars. I think that's a KPI that no one's looking at, that the whole world embraces as the standard for excellence. I think that needs to be looked at, because these facilities don't have good ratings, and that is a clean feedback loop from us to you. And no one in leadership, I think, has ever looked at that, and no one think anyone is looking at it.
Well, thank you very much. Ranking Member Brownlee, do you have any closing remarks?
I just want to say I really appreciate having this hearing. I've been on the committee, I think, for 12 years, and I'm not sure that we have had a hearing on this. So thank you for bringing it forward. I've learned a lot, and I think I've got a pretty clear idea. I think that the chairwoman's just sort of laid it out, too, in terms of where we need to go on this and in terms of trying to make it better. But the VA should, when it comes to prosthetics, they should be the very best. They should be on the cutting edge. They should be world-class. And, they should be leading the pack across the country. And I think there's probably, the VA is doing a good job across the board in certain places, but not everywhere. And I think someone talked about rural America too, where it's even a greater challenge. But I just think we need to kind of really work on this to make sure that we are providing our veterans who've served our country you know, losing a limb is, I can't imagine. Honestly, I can't imagine what that would be like. But I do understand how impactful it can be if things aren't working for you, both physically and mentally. So anyway, I think we've got some work cut out for us, and I appreciate you having the hearing, Madam Chair. I yield.
Well, thank you very much, Ranking Member Brownlee. I thank all of our members who are here today. I especially thank the VA. I know that some of these comments were probably not something that you particularly wanted to hear, because it sounds like you're truly trying to give state-of-the-art care to all of our veterans, especially our veterans with amputee and limb loss. I'd like to thank our witnesses on panel 2, Mr. Ramos, Ms. White, and Mr. Brown, for being here and for your courageous testimony. Not easy to come all this way and bring that forward. And that we do need to do a better job of holistically looking at our veterans and our veteran population. So I'd like to thank everybody for their participation in today's hearing and for the great discussions we've had on this important topic. And I would agree that we have a roadmap for where we need to go and how we need to assist the VA in order to treat you better to the highest level of your functionality and activities of daily living. As I've stated before, ensuring that our nation's veterans receive the highest quality of care is my top priority as chairwoman of the subcommittee, and holding the VA accountable and providing proper oversight is the job that we on this committee have been tasked with. I'm committed to working with my colleagues and the department to ensure that high-quality care is delivered to our veterans. I look forward to continuing these efforts to working with all stakeholders involved. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so ordered. I thank the members and the witnesses for their attendance and their participation today. This hearing is now adjourned.